Janet, can you hear me?
Yes,
Sorry, Sid, you can hear me?
yeah.
Cool, thank you.
Yep.
Starting the meeting over again.
I kept working on my slides and not even a later.
Yeah, I
transition. Did
I
you
saw
find that one.
yep, I saw him.
It says final or something. Like
Yep, yeah, I downloaded these are.
I have a laptop if you need it, or is it
No,
just
no.
right there?
Nope, we're all good.
You'd rather
All
have it
all
in
you
there.
need to do is just present.
Perfect.
Yeah. I prefer when people bring in their own laps, I'm like, ooh.
Yeah.
It's
It
an
doesn't
extra,
load in.
it's an extra
Check.
variable that I'd rather not deal with. Let's see.
It has like a presentation mode or something like.
Yep.
I have some
So
like fly in like.
yeah. And I'll show you right now. So you can see like right here, and then we will open a presentation mode right now. Then you can see the screen, all the screens, and then you'll just see this. So present slide, next slide,
That's super.
and then
That's better than I usually get.
then the next thing, so laser, right? Point it at the wall.
Okay.
Move up, because a lot of presenters, what they do, they just do like this and then they can't find the laser.
Okay.
So push it, point at the wall and move up first.
Okay.
And then this is to advance your slides. Cool. And then this is to go back on your slides.
And do I aim, otherwise aim the advanced thing anywhere?
Yeah, so you can go like, you can go here.
Where is it there? That's.
No, so the USB is in the computer right there. So the drive is down there. So as long as you're like,
Just Wi-Fi?
yeah,
Or.
Bluetooth.
Yeah.
Yep, so then you can just go around and do your thing.
Sweet.
Yep.
So, yeah, I have an assistant, Alexis, coming over to our office.
Oh.
Your person.
Hey.
She might kind of like ask it on Teams or something.
Yeah.
Are you, like, my wife actually works at Luke's and she's like, oh, yeah, you can watch it at Luke's.
Yeah.
Is it on Teams also?
So this is on Teams, yeah.
And is it recorded?
It is recorded. So to answer your first question yesterday in the email, I talked about it. So Eric is this individual who one is like, so we are being recorded right now as we're speaking. So that will all get recorded and downloaded. Garrett also, he's like our, photo video person. He'll be swinging by probably 15, 20 minutes, post up his own camera, and he also records it there. So you will contact him about the recordings, because he keeps all the recordings and everything. Yeah. Cool. The thing with Luke's like, outside the VA, and I think I'll have to talk to the administration, I don't know and stuff about it. It's like, I don't, like, people can have access to it, but having, and yeah, I don't know. I mean, but I will tell you, everyone's always invited to come here.
Yeah.
Like, they want to come, definitely just swing on by. Also, everyone's from Luke. So we have like, a lot of people from the ICU anyways, the attendings there, they cover the scan here.
Yeah.
So I always invite them if they have time. But I never know this Dr. I don't know, Dr. Krug. He was one of our associate program directors here till last year, but now he's the head of medical education for all of St. Luke's in Idaho. So I know Luke's is kind of doing their own thing, but Krug and I have been talking about like, do we want to stream the VA, like be even like essentially the grand round of Idaho, and then all throughout Idaho, all state system.
Yeah.
So we've been talking about that too.
Well, if it's recorded,
Yeah.
that's probably the more important issue with it. I mean, have people sitting in their office that are like, even, but
Yeah.
if it's recorded, I can share that later.
Yeah. Eric will be here, you can reach out to him and he'll just send you the recording. Yeah.
So you're the chief this year?
I am, yeah.
What's your plan?
I'm going to, University of Minnesota for pulmonary critical care. Yeah, so I got accepted there.
Is that in
Minneapolis. Yeah. So I'll rotate through Barry, VBA, Hennepin County, and then we have like two other,
in internal medicine?
pulmonary critical care.
Oh, okay.
Yeah.
So you've done 3 years of medicine.
Yeah.
Were you, Seattle also?
No, here, always did. Yeah. So I did 3 years, here, so then like my single attending here, and then I head over, I move in July. Or actually I move in mid-June to, Minnesota for fellowship. Yeah.
Thanks.
I know, that's not saying. Hopefully things will a little bit calm down. We have, my co-resident last year. He actually took a job as an outpatient doctor up in, Minneapolis, so I've been like kind of talking about how things are like shaping up there. But I know like the university, they kind of send us, like the program director and everything. But they're just like, this is not normal, right? And they're like, but they're just like, this is not normal. The university, the university president also sent out like the whole thing to the entire school, not like letting everyone know. So, but yeah, hopefully things like calm down before I head out. Yeah.
They already are.
Calm
It's
down.
changed a little bit.
Yeah. So we'll see. Cool.
Yeah, Minneapolis Heart Institute. That in group, I would guess they're part of university training too.
Gotcha.
It is something special.
I know. Yeah, I've never been to Minnesota before, but I know like from the home critical care, we also head down to and do like stuff and all the ultrasound stuff down there. So we'll see. Yeah. Well,
Where are you from?
Arizona. Well, I was born in Chicago. It's like kind of like a little bit north Midwest, but my family, we moved to when I was like second grade. So
You know where you find up?
yeah. Either here in Boise, so like so it's the St. Luke's like charge of like all their physicians, kind of like the main physician person that you talk to, Dr. Nobar.
So
Yeah. So she actually did her fellowship at University of Minnesota. So I was gonna reach out to her probably like I don't know, end of my first year, second year of fellowship. We have a yeah. I know a lot because a lot of them we do our ICU there and out, but like a lot of their attendings they also attend here too at the VA. So I know them. Yeah. So like I know, and then like I was on Seattle, I worked with like some of their home curriculums. I kind of know that. But then, Al, we had a former graduate, she works there now. And then Pidcock is the director there, ICU site. No, Wesley Pidcock. Yeah, because I interviewed, because he helped me get an interview with UC Davis when I was looking at fellowship programs. So, but
I
then,
did pulmonary UC Davis.
oh, really?
In med school.
Got it.
Like your report here.
Oh, like the rotation?
Yeah.
Yeah, yeah,
That's a great.
yeah. So I interviewed them, so St. Al's, I'm also gonna talk to them, hopefully they'll talk to me. But then the other place would be Flagstaff, Arizona. Cool, yeah. See. Awesome. Yeah.
Hello, David, how are you?
Well, how are you?
Graham, my neighbor. Graham, what?
Oh, nice to see you.
Yeah, it was like 100 yards from my.
Oh, really?
100 yards from my house up in Hill. We're just down on Nature View, right below.
Oh,
That
okay.
new little cul-de-sac right below you.
Yeah.
Um,
Oh, the one, yeah, the one that comes up and, yeah,
yeah,
and the trail goes up to almost my house.
yeah, exactly.
I didn't realize you lived down there.
Yeah,
It's good to see you.
yeah, good to see you.
And I understand that I definitely is living a little
It's panning out. It was a heck of a project.
when you
I
have
made a lot of mistakes, learned a lot, but we're steady.
any of you been in private practice?
I mean, when I first came here, bad key and all, we were private and then we had a pretty big group of like 16 or 18 and then Luke's bought our practice. So I came into a private group that was pretty big for 4 or 5 years and then we were employed thereafter. So I didn't know
I
much
can
about it.
imagine that's the new person in a large group who has a lot of, various people running the practice. Even that involved in
No.
management.
Not really at all. So
That would get
I'm still honestly not. I mean, of the 4 cardiologists who broke away, I'm still focused on the medical stuff. I'm not really big into spreadsheets and finances. Honestly.
Wise man.
But I'm thinking the medical part. So
Yeah, that's why we did.
it's kept me energized and invigorated from my learning stuff.
So I retired,
Yeah,
but, kept my life. And most of it during my
yeah, that's an awesome idea. Do you see Erickson on it? He used to come to our meetings after he retired for a little bit when he was at Luke's, but I didn't know if he always seemed to kind of want to stay involved. I haven't heard lately what he was doing.
Yeah, I haven't seen it. So
Yeah,
I closed my office in May of 7.
yeah,
And then I did local counties with my wife, like 4 years old. Little sort of life. Yeah. But, it's really good, especially when you see local counties. One of us was really good. And all 4 years within the same place. Really special.
yeah.
You know yourself. You don't want to
Taking
say
that
policy. ER calls you in a panic. Once you know who the ER players are,
You contact.
you might say, okay, well, keep an eye on it and I'll be there in the morning.
Yeah.
Versus I'm up on it.
Yeah,
So that was good. And then, they, in a different direction. I did, 6 of them. About 5 months out of Bismarck, North Dakota. It's actually, it turned out to be the same hospital where like by the name of a cardiologist over at St. Al's had come from. Had to dream, we have somebody like practice in this hospital. And even the guy that was he took over the practice. Hey, cool. And tell me who the other players are.
Dan Newman and Josh Moses are 2 EP docs. And then Fred Costello is probably.
I know, yeah.
Interventionist.
And I know Dan's wife, but she wasn't. Yeah, no, yeah. Well,
Yeah, she's actually kind of just on the side doing a lot of our social media and front page updates and all that stuff. So, yeah, she's pretty helpful, very helpful, but I'll let her.
it's always a better day when I run into her locker.
Yeah, it's great.
She was great. Yeah.
Yeah.
And there's the other EP.
Josh Moses, he came to Indiana University. He was at least about 5 or 7 years.
Yeah, I remember the name.
He's pretty,
Don't know that I did.
really medical focused, not really in the business of parties. So he just likes to do a lot of solutions, devices, and
And there's another EP working too.
Newton, Lauren's husband, Newton, that's that already.
Yeah.
Yeah.
But I mean, for group like four, it's kind of when you've had the EP.
Yeah, yeah, we need, Brad and I both need help. Because I'm the only guy, we're doing like PET CT imaging and stuff, I'm the only guy reading them, and Fred's the only interventionalist, so we would love to get to 6. We have some pretty good prospects in the near future to cover interventional, but I'm still looking for an non-invasive imaging backup.
And you're not.
No. Yeah, I do a lot of CT, PET imaging, and office.
You
stuff.
do that.
I do angiograms, regular casts, EEGs, cardioversions. I kind of stack those up on Friday mornings. Yeah,
I'm really glad.
no weekends, no call, no rounding. We don't really have ER or a hospital. It's all ambulatory. It's great. So if people are in urgent need, we send them to Roots or else. But, and they've been working with this fine. I mean, they usually send them back to us. But we do a lot more preventative ambulatory stuff.
And experience. Anyway, a patient called me, myself, from 20 years before. Like I remember this guy, people that way.
Wow.
He was getting care for the VA. And he was having substantial. And he, by his story. We. Off one room. Which.
Yeah,
That's a little bit.
yeah.
Waste. But then he. So I called, hospital. Got him that week. And,
Recently at High Desert, really?
yes, it was that, I guess.
Yeah.
It wasn't super recent. Anyway, but guy needed stents. He took care of it. And it's just really urgent that the cardiologist here would not do what here was
Yeah. I mean, we're busy just for that aspect for access. We can't figure out how to get into the big system. So a lot of people come over because we still have accessibility. People can usually get in quick enough and it's made our practice grow. But yeah, it's pretty good.
Well, you get enough stuff.
Yeah, that'll be solid. Probably need a little bit of testing. Yeah. I'll get my stuff.
Yeah,
in,
yeah.
and I'll do some stuff here.
Yeah.
Um,
Hey. Then. Hey. All right. So that's the three. Last. So where he sells some sticky fingers. Oh, we're just taking with them. And then. I would do. Yeah, and I should be able to. No, that's what I got it. I thought.
And I'm pretty good. How do you like to? I'm just going to that. Nice. Learn without the leadership. So this is. I thought about that man. It's a week. You can always say that about it. It's a week. So that was plenty of treatment. Fine. Yeah. See anything interesting? No. After the terms possible. Oh. Classic. It was in the box. Is that all that we need to post? He's a collector. Yeah. He's well. He is my least favorite. He's put down tomorrow. No, today. It's Thursday, right? Yeah, my first patient. Nice. See you every month. For an hour. Every one follow-ups. One. Because he just loves me that, you know, it's more debating. Oh, really? It's so.
Do you mind if yeah, let's do that. And Eric should have this. So hopefully. It's so important.
So it's nice.
Oh.
Yeah, you're working out for it specifically.
I'll put like right here. That way, because like if you move around, just speak into it really quick.
That's one.
Good doctor, Bostack's gonna save his life. Yeah.
Sure, but,
Nice.
so, can you flip it?
I'm not.
Or, am I, there's a easier.
Yeah. I'll refer to you. No, they're not.
Thank you.
I.
Nope. You're.
He's gonna have.
I'm gonna do that.
Hello, test 1, 2.
Nope.
So then he's got 17 years of time. They don't need to take care of him.
Test 1, 2. Test 1, 2.
Okay, your pocket. So do either pocket, yeah, whatever.
Yeah, so.
There are legal guarantees to this.
Yeah, keep in mind, give me a favorite.
Nice, there it is. There it is.
Yeah.
Great. And then just push the slides. Thank you for watching.
There it is. Okay, well, don't say he's getting enough.
That's fine.
There you go. Got it.
I'm drunk, like, it's pretty cool. Oh, you're. That's my thing. You got some patients. Hey, you look at your kick out this. California. So, well, there's not answers, I just have, both testosterone. I was prescribed myself testosterone just in trouble. So, you want to join the party for a nice percent. Well, hello, good morning.
How are you?
Good, how are you?
You know?
But, so I was like, oh, well, check your testosterone, you know, but yeah, not to keep it. It's not. It's about. I'm just like,
Yes, now I'm sure you need or as much testosterone as you're taking. Like password. And he also did not like to worry about it. Or 10 times. I think it's be a lazy. So I started. Yeah, great. Thanks for letting me come. So it seems really tired after having these joint children. And I was having 5 years. It's not even the patients that should have these modern breast cancer. Started business in 2020, right before COVID happened. Business blocked. Young area bought a kid. This was pretty something. His business was in line. His principal. His name. They got exactly. But it's not accessible. So it's like I think I still something. It's psychiatrist. I don't know what help you in the psychiatrist was like. So now it's going to be something. And it's something way back to let's try to loss. And what to do? He started this. About it. Touch the interface of that one. Try to culture. Don't. Words there. Nice. It's not an industrial event. As far as I choose it, that's too hard. Okay. That's very common. Don't bring copy. I'm forgetting behind me. Maybe. It's very brittle.
Hi. Fine. How are you? Nice to see you. How have you been?
Good. Looking forward to hearing you speak to me.
Good. I hope I can share something useful. So, are you?
Yeah, that you. Trying to. I actually experienced companies that have done. I don't let you see. Still, it's not like it's. So you're gonna be doing that. I'm doing some records digging. Hopefully, into 2 years as advertised.
That's awesome.
I turned 60 actually. So I think I'm like 63. Yep, that's my plan. Sean and I are both talking. It's really hard to get this country. I just started this on our.
I'm back here and see what never been.
You probably told me what it is because it's on my bucket list. But it's like out to the biggest area in March with the mountain bikes.
I'll let you.
No worries.
Good morning, everyone. Morning. This morning I have Dr. Hinchman, who's a cardiologist at Denver Heart and Vascular, with a special interest in prevention. He's been a local principal investigator for over 100 clinical cardiovascular research trials. Give it up for Dr. Hinchman this morning.
All righty. Thank you very much for taking a moment this morning to hear about what I think are some of the most practice-changing pieces of new information we've seen over the past 12 months that you should be aware of, as well as some advances in imaging that are taking technologies I would have told you a year ago are the greatest things since sliced bread and already making them obsolete because of leapfrogging of AI technology and the way we're able to look at coronary arteries today. Before we go further, I just want to remind you that cardiovascular disease remains overwhelmingly the condition that's more likely to kill people in this room than any other condition. It's still the leading killer of Idahoans, of Americans, of people across the globe. And it really does not need to be anymore because our advanced imaging lets us see the coronary atherosclerotic process brewing decades ahead of time before it causes symptoms or kills people. And we understand the biomarkers that we can track that are driving its progression, and we have effective lifestyle pharmaceutical interventions that can stop the process in its tracks. So really the only obstacle I see in cardiology in the next few years is just implementation, which is a huge obstacle in cardiology. I find it interesting to contrast to my oncology colleagues who will diagnose cancer, say, we're going to give you this toxic chemo that'll make your hair fall out, make you throw up, suppress your bone marrow, make you septic. And overwhelmingly, they're like, sign me up for that. Whereas if I tell my patient, I can predict you're very likely to die prematurely from a heart attack, and we have a once-a-day pill or maybe a twice-a-year shot like Leqvio that will likely eliminate that process from producing symptoms or taking their life. Most people are like, yeah, I don't really want to do that. I'd rather adjust my odds naturally. So this is a whole other topic, but I think the biggest conundrum in our practice, I think of the VA, your patients heed recommendations pretty well. In the private world, there's a lot of requests for testing, but not a lot of interest in altering risk with intervention. So I'm going to run through things pretty quickly, hopefully stimulate some questions and lively discussion at the end, but we'll go through some important pieces of information I think you know about. These are my disclosures. I'm a local investigator for some imaging and pharmaceutical trials, speaker for several sort of pharmaceutical companies. They don't really play a role in any of the info from today. I'm going to start with the ABCs like lipoprotein A, apolipoprotein B, and C for CT imaging first, and we'll go through a number of other things from there. So what is it that you need to know about lipoprotein A? If you're not aware of this molecule, you need to know about it. It's not that complicated. It's just a small protein that is bound to a portion of our bad LDL cholesterol, and that protein makes it highly atherogenic and thrombotic. It not only causes plaque progression, but it forms blood clots. So it puts you at risk for early heart attack, stroke, aortic valve stenosis. It is 90% genetically determined. In fact, if anything, it's a low carb diet that make your LPA go down, but can't by very much. And we've arbitrarily decided that if you're in the top 20% of people across the normal spectrum of LPA, that's considered abnormal. But there's a quirk in this issue. In fact, last night reviewing labs, I swear 50% of my patients were measured with LPA in nanomoles per liter, the other half in milligrams per deciliter. And they're very different scales. They're just different. It's hard to compare the two. But I've had patients say my LPA jumped like 80 points from one year to the next, and that's overwhelmingly likely to be because they did a different assay. So pay attention to the units. It matters. We haven't decided which one to use. It's a problem. You can affect this with lifestyle. It really doesn't change over time, but you need to know about it now because there are about 7 drugs in research trials right now in phase 3. We finished a twice-a-year shot called lepodisiran. We finished enrolling. We're watching outcomes in that. We now have the first oral therapy once-a-day pill called muvalaplin at High Desert to lower LPA. So if you have high LPA patients, we can put them in a research trial. And these, even the injectables drop your levels like 90%, the oral drops it by 80% with the once a day pill. But even if you don't want to enroll a patient in a research trial, it's important to think about aspirin, which I'm a nihilist about for primary prevention. I really believe we're much more likely to induce bleeding complications than prevent heart attacks and strokes using aspirin in primary prevention. But if there's any benefit across our population, it's the people with high LPA because they're prothrombotic. They have higher thrombotic events and they have less bleeding complications on aspirin. If you look at this curve of people that had a LPA over 50 milligrams or 100 nanomoles on the top curve, they do much worse than the general population. And aspirin moves this significantly closer to the normal population outcome. So if you want to use aspirin in primary prevention, think about it in the high LPA people, over 50 or 100 nanomoles. There is a new lipid lowering agent coming around the corner on the block. We have it in a research trial at High Desert. This is a CETP inhibitor. And we did study drugs like dalcetrapib when I was at St. Luke's. These are felt to be good HDL raising drugs. They raised HDL by 60%. Didn't do a thing to prevent heart attacks at all. But this CETP inhibitor is incredibly potent and it actually lowers LDL pretty effectively as a non-statin, lowers LPA, lowers ApoB, and even has benefits in the brain with preventing markers of dementia. So you will be hearing more about this CETP inhibitor as a statin alternative, especially if you have high LPA. We're in a trial just starting at High Desert called the Rubens trial. If you have anybody with diabetes or metabolic syndrome, can't tolerate statin or they're not a goal, we give them this once a day pill with or without Zeti and watch their markers over time. That's A. B is another molecule you really need to know about, which is called apolipoprotein B. Each of these tests can be obtained on a simple blood test. You do not have to be fasting to check your LPA or ApoB, but these are the most important lipoproteins to check anymore. Why do we want you to switch to ApoB? Because it is more predictive than LDL, total over HDL ratio, non-HDL cholesterol, any which way you want to slice your lipid panel. ApoB outpredicts any of those complicated things. And you know, we have a lot of patients that say, well, yeah, my LDL is high, but I'm protected because I have really high HDL. We've learned that's nonsense. If you have a low HDL, that's pretty worrisome because it probably suggests you're insulin resistant. But a high HDL is really not protective at all. It just happened to be in population models that a low was bad, but a high one is not protective. We learned HDL affects cholesterol efflux, and it needs to be measures with HDL activity rather than particles. So we can't make sense of an HDL level on a blood test anymore. But your risk of athero, heart attacks, and strokes is mostly driven by one marker called ApoB. And that's because all of the bad particles, like LDL, VLDL, triglycerides, cholesterol remnants, have one ApoB molecule on them, and we can measure it very easily. The good ones, like HDL, don't. They have ApoA1 on them. But if you just measure the number of ApoB particles, you can tell who's at risk for cardiovascular disease. Because it seems like the particle number is more important than how many LDL or how much absolute cholesterol you have. It's how many bad particles you have. You know, if we have somebody with two big fluffy LDLs and someone else the same total amount of LDL cholesterol in 30 small ones, the ones with 30 small dense ones had much higher events, probably because those small dense LDLs are too small for the liver receptor to recognize them and take them out of the bloodstream, and they circulate forever and cause more plaque. So it's important to just measure the ApoB. In fact, if you look at this peculiar set of outcomes, we like to drive your LDL under 70, ApoB under 80, ideally LDL now under 55, ApoB under 60. I mean, my whole career I've been taught to focus on LDL and get it under 130. Then it was 100, then it was 70, now it's 55. But We need to change our thinking now to measure and focus on ApoB because it is much more predictive. In fact, if you have a low ApoB, you're actually in worse shape if your LDL is low compared to somebody with low ApoB and a high LDL. Why is that? Maybe because we're pretty good at lowering LDL and you can help these people over time. Similarly, if your ApoB is high, but your LDL is low, that's a very worrisome condition. Probably because our pharmaceutical industry and doctors haven't really focused on dealing with cholesterol remnants, triglycerides, things that are leaving residual risk. We know how to fix LDL, but the ApoB is much more predictive. And as much as the ApoB is far superior to some of our other markers, I just told you about lipoprotein A, ApoB. ApoB does look to be a higher hazard ratio than a high LDL or non-HDL total cholesterol. This is from almost 40,000 subjects in the women's health study tracked over 10 years. What vital markers are going to predict cardiovascular events? And I focused on LDL my whole career, but in fact, other things are much more important. And you may be surprised what the leading biomarker was to predict cardiovascular outcomes. At the top of the list was something called the LPIR. I don't know if you've checked this very often or read about it, but I have just learned about it, and it's incredibly potent because it is a 6.4 hazard ratio driver of atherosclerotic coronary events compared to like 1.3 for LDL. Even for ApoB, it's less than 2. And the clinical conditions that really put us at risk for cardiovascular disease, overwhelmingly potent is metabolic syndrome and the more severe version of that, diabetes. So as much as I've been taught to be a lipidologist, as cardiologists, we have to be experts in insulin resistance and metabolic syndrome anymore to prevent heart attacks. So we're missing most of the events. You can draw a blood test in the fasting state to get your LPIR. It is a nuclear magnetic resonance assessment of 3 particles, the particle size and amount of LDL, HDL, and VLDL. But it's compiled into a score that tells you how likely you are insulin sensitive or resistant, which is a really big deal. Now there's a even fancier version of this that was improved upon at Duke University with the addition of 2 branched chain amino acids called the diabetes risk index. We have this at LabCorp. This is my favorite test now. You do it in the fasting state, but your DRI tells you if you are insulin resistant or not. And that's more important to know than your LDL or any cholesterol or your ApoB or LPA. So I encourage you to think about looking for insulin resistance with these new tools because they are potent. In fact, the A1C, I no longer use or recommend for looking for prediabetes. This has been incredibly falsely reassuring to people or misleading. A1C is useful if you have diabetes to track your glycemic control. But to see if you're developing insulin resistant, are you pre-diabetic or not, the A1C is incredibly faulty. In fact, I have high A1Cs that have been bouncing around forever, and I've tried to figure this out with glucose tolerance tests, the DRI and stuff, and I'm not insulin resistant at all, even though my A1Cs are high. I was asked to do an interview with Outside Magazine about this guy, a runner, who has high A1Cs. He thought he was a really healthy guy, and he goes, but I have pre-diabetes. It turns out this is probably not the case at all for many endurance athletes, especially because we don't know exactly why, but a lot of people with endurance training have high A1Cs. Maybe because your body has no idea if you're going to take it on some 30-mile bike ride or 10-mile run, and you need to preserve glucose for your brain. You can fuel that exercise with a lot of free fatty acids and fat, but if you're going to take off and do something crazy like that, you need to have sugar around for your brain. And it's felt that those athletes keep sugar levels higher at baseline should those things be coming along. But nevertheless, a high A1C in an athlete is not necessarily a sign of prediabetes at all. I think it's good to look further into insulin resistance with either LPIR or DRI. Another sort of revelation I've had in the last year that was finally put into statistical evidence and published just a few months ago in December, is that our risk calculators are failing the overwhelming majority of individuals that are having heart attacks. We're encouraged to use Framingham risk score. Now even the prevent score is felt to be a better tool. But it turns out when you look at people that are having heart attacks, 90% of them 48 hours before their event were not declared to be high risk by even Framingham, or even 97% of them by the better prevent model. Why is that? Of course, if you have high Framingham risk, you are more likely to have a heart attack. But there are so many numerically more people in the low to moderate risk category that we're missing 90% of the heart attacks. So for an individual, I think these risk models are failing people. And we can do better than that. We can see the disease brewing with advanced imaging, and that's why in a perfect world, I prefer to do imaging first to see if you have the disease. And if you do, then we try to motivate you to change, figure out what's driving it, change your biomarkers with interventions. But think about looking for the disease with imaging. If you've had a CT scan for maybe lung screening or any scan for chest pain or something, look to see if you see athero. You don't need to then do a calcium score. If there's plaque in the arteries, you're in a category that we know we need to do things differently. So I scroll through the last CT scans done in Idaho on IHDE all the time. And if you see plaque, we know we have to do something differently. But the risk calculators don't really affect my my intervention strategy at all. I don't know if I can play this little movie or if it's worth trying to do, but there are two new imaging techniques that I think make our imaging of coronary artery disease light years ahead of treadmill testing and stuff we were just doing 3 or 4 years ago. One of them is with the CT scan, because we can see calcified plaque in the arteries easily on scans being done in ERs all the time. Or if you want to get fancier, we have ultra-fast CT scans that spin at 70 Gs of force and get a freeze-frame single heartbeat picture of your coronary arteries and show us plaque in those arteries that we can track and modify over time. And we've learned that for symptomatic patients who are trying to discern, are they having symptoms of ischemia, which does put them in that high risk category. Maybe they need reperfusion or revascularization. The best test we're finding now today, which has become the #1 class 1 indication across imaging models and recommendations, is a PET CT scan. And there are several reasons why our typical SPECT imaging, stress EKG, stress echo, are actually losing utility because of the way coronary artery disease is changing in our country. In fact, when we look at the US or even Germany recently, the number of STEMIs is going down, but people are presenting with a higher incidence of non-STEMI. When we take people to the cath lab, the amount of obstructive disease we're seeing is going down, and the percentage of people having findings of non-obstructive disease is going up. And that's because, in part, I believe, that we've become good at lowering LDL cholesterol with lipid-lowering therapies, but what's killing Americans are of all the other metabolic conditions like obesity, hypertension, diabetes, that cause more diffuse disease that we can't really see on a stress echo. But we can get clues about this on PET CT imaging. And these more diffuse drivers of athero are causing more disease. So what's so cool about the PET CT scan? It gives you this wealth of information that can sometimes be overwhelming to me reading them and to my staff who I try to convey the results to, but there's a lot of important information. We can see calcification of the artery. We can see relative perfusion defects that are corrected by attenuation with CT attenuation correction protocols. We can assess the resting EF and change with stress, which tells us that there's high risk findings. Transient ischemic dilation, but most importantly, that rubidium tracer can measure the blood flow through your myocardium at rest and then with stress. And those findings tell us more than we ever realized about the heart. Even over the last couple of years, we started to learn what all this stuff means. So the idea that you have a normal stress test or an abnormal stress test is gone in my mind, because the PET CT tells us all these nuances about the heart that are much more useful than you need a cath or you're fine. It's a little complex, but it's worth understanding. And the biggest trial that we looked at to compare all these trials, all these methods of looking for coronary disease, PET really had the overall best operator area under the curve finding at 0.9 compared to CT or SPECT imaging. It can see calcified, that through calcified vessels with CT still kind of gets hung up on with ballooning artifacts. It can evaluate people that have had stents, bypass surgery, where CT really suffers. And there is an important role for CT that we'll talk about shortly, but if you have symptoms and you've had known coronary disease, the PET perfusion imaging tells us what we need to know. And in fact, if you have a normal myocardial blood flow reserve that doubles with vasodilator stress, the likelihood that you have life-threatening coronary disease is only 3%. I did actually have one of these cases that blew me away, and I've talked to a lot of experts about it. It's extremely rare, but it's possible. So if your patient has symptoms, always respect that. But overwhelmingly, normal flow reserve tells you you probably don't have life-threatening disease. Why is that? Because the single obstructive lesion in a big epicardial LAD vessel is really only a small part of the story. This process of athero occurs in the smaller vessels, in the microcirculation of the heart, and the PET image and blood flow analysis can tell us about that. And in fact, when we take people and evaluate them for possible CAD, among those who have non-obstructive CAD, a huge portion, almost half, have impaired blood flow, and they do terribly. Even if they don't need a stent, they have athero affecting their microcirculation. We call that coronary microvascular disease, CMD. We do have medical therapies to recommend for that, like maybe Renexa and other lipid-lowering therapies. But just ruling out the single obstructive lesion in the LAD that needs to be stented is not enough anymore, because that diffuse disease is much more common. And we've also just started realizing that when your flow reserve is impaired, if it's because you can't augment your flow to double, it's probably because of a clogged artery. So normally at rest, your flow rate should be about 1. With stress, it should double. So your flow reserve should be at least 2. Then you're in pretty good shape. 3% likelihood that you have something worrisome. But we've also started to learn that if your flow reserve is less than 2, only because your resting flow rate is really high and it's making that ratio low, like maybe your resting flow is 1.4, and you can augment to 2, and that stress flow of 2 is considered normal, but your ratio is low because you have high resting flow. Those people are in this kind of peculiar category of sort of intermediate risk that I kept coming upon, and I said that this isn't a totally normal finding because these people don't do very well. We started to recently realize in the past few months from some big analyses that if you're above this line, flow reserve over 2, you do well. But if your flow ratio is under 2, and it's because you have really high resting flow, you're overwhelmingly likely to be hospitalized with heart failure and die of heart failure. Because your heart is idling at like 6,000 RPMs because something in your myocardium is demanding enormous blood flow just to sit at a desk or sleep. Whereas if you can't augment your flow from normal at 1 up to 2, that portends a concern for ischemic events. But a low flow ratio could mean if you have high resting flow, you're at risk for heart failure. If you can't augment from a normal flow to double it, you're at risk for ischemic events, probably need a cath. So these findings are just they're just kind of revealing to us what we can tell patients and try to help them. What do you do if you see high resting flow? There is some data that the GLP-1s and certainly we know SGLT2s help people with HFpEF. This is a large group of predominantly women who have dyslipidemia, diabetes, and they have HFpEF. And it's not a good finding to see high resting flow. So these things are teaching us a lot about what else we can tell somebody about their heart instead of you don't need a stent. That's for the symptomatic people. I like the PET scan. If you don't have symptoms, I think there's utility in screening with CT imaging. The cheapest, simplest test we do for $150 at High Desert is calcium scoring test. But again, you don't need that. If you can find a CT that was done in the Lucia or something, or here, that showed calcified plaque, that's all you need to know. And if you see calcium in the coronary artery, that's not good. Your prognosis is not great. If your calcium score is 0, that's pretty helpful. But the concern about this test is that it can be falsely reassuring, especially in younger people, 40s, 30s, 40s, 50s. Because we've since learned that calcified plaque doesn't cause heart attacks at all. It just happens to be associated with the stuff that does kill people, which is soft, lipid-rich plaque. They tend to run together. That's why the test is useful at all. But if we take, again, the portion of people who are having heart attacks, not the general population, but look at the people that are having heart attacks. Of those who had had a CAC a little over 4 years ago, 31% of them had had a CAC of 0. So, yeah, these tools are great for population assessments. But in an individual, to say your CAC is 0, you're good, is falsely reassuring. Because a third of heart attacks had a CAC 0 4 years earlier. The other problem with CAC scoring is you can't track it over time. Because our treatments actually transform soft lipid-rich plaque into hard and calcified plaque. So if you get a calcium score of 100, and then 4 years later your score is 200, I can't tell if you're getting worse or if our interventions are very effective and we have calcified and stabilized all your plaque. We can't really track it over time. Because we've seen that statins actually get rid of low attenuation plaque and soft fibrous plaque, and they intensify calcified plaque. That's what we're trying to do. Get rid of soft plaque, calcify your plaque. So just looking at the calcium is kind of old news in the atherosclerotic process, whereas seeing soft plaque tells us more about what's going on in a more sort of acute state. So ultra-fast CT with that super fast scanner and an IV can see soft lipid-rich plaque that the calcium score misses, and we can track it over time. We know the total burden of your plaque is worrisome. The amount of soft plaque is predicted. And very recently, we've seen that other markers like perivascular inflammation are even more worrisome, which is, I think, the coolest part of what I hope to show you today. We have this clearly AI platform that uses AI to analyze all those voxels of the 3D CT data set, and it can see small amounts of plaque that radiologists can't. And it does it in a couple of minutes instead of 8 hours. So we use this AI plaque analysis, and we've seen if you have super dense, bright calcified plaque, that doesn't cause trouble at all. But people that have this soft, low attenuation plaque vulnerable to rupture are in trouble. In fact, it's this mixed or really soft necrotic plaque that tells you you are at high risk to developing an acute coronary syndrome. The total or calcified plaque doesn't really discern if you're at risk for an acute coronary syndrome, but that soft plaque is worrisome. As quickly as within 6 weeks, we see higher incidence of coronary syndrome if you have this stuff on your scan. It's alarming. And we've even seen certain morphological features like the signet ring sign, like the soft plaque within a hardened plaque that make us more worried about the rupture vulnerability. This is all being studied right now. So if you have a CT scan that looks at that soft plaque and your risk is low, you can go out even 10 years with even more reassurance than that calcium scoring test offers, especially in younger folks. It's a pretty great test. And like I say, we can track it over time. If clearly they have a comparison module that says, yeah, compared to 3 years ago, you got rid of the soft plaque and your calcified plaque went up, you're on track. You're doing good interventional therapy. But the game changer that is coming hopefully in 2026 that will, I think, make a paradigm shift in the way we look for and track and treat coronary disease is something called perivascular inflammation, which we've known about for a long time. Peter Libby in Harvard has been talking about this forever. Paul Ridker got our attention checking CRP levels and saying, yeah, if you have high CRP, that's a concern for heart disease. But we've never, I was involved with I got to meet them. We did a protocol using methotrexate in people who had bypass to suppress their inflammation. Didn't do a darn thing to prevent heart attacks. And colchicine's been similarly hard to make sense of because I think inflammation is a marker of disease, but it's not really a driver. So suppressing the marker isn't really affecting outcomes very much. But this tool can see inflammation in the coronary arteries off that CT scan with incredibly potent predictability. It's a tool out of Oxford, England by a company called Caristo. And the reason it's better than all the perivascular coronary inflammation studies is because they took a ton of time to figure out what the two voltage settings on CT were and how they affect this measurement, how to standardize it across scanners all over the globe on different continents. And they have this tool that can tell you if your coronary artery is inflamed or not. Sounds pretty cool. And they can also incorporate clinical scores, plaque morphology, and then do you have hypertension or are you a smoker? And you get this FAI score. And if you add the clinical features, you get a carried heart risk score, they call it. That really is a number that tells your patient their risk of heart disease, which can be motivating. They've shown how it changes behavior and behavior. And then they did a bunch of machine learning over thousands of CT scans across the world, especially in England with their national health system. And then they trained the model and they tested the model going prospectively. They said, let me look at your CT, let me look what happened to these people. And the real world outcomes you can't even see over the machine learning predicted event because they were identical. They trained a model that is highly predictive in any country on any CT scanner. It's pretty powerful. It looks for that adipose tissue around the coronary artery changes when there's molecular signaling of inflammation, and it makes those fatty cells a little less fatty and a little more water content and a little more attenuation. And these are things you can't really see visually, but the machine can detect those changes and give you an inflammatory score. I thought this was kind of too good to be true when I was seeing these curves. But then we had a case at High Desert just last year that blew me away. We've submitted this for publication. It just got accepted. It is a fascinating story. 61-year-old guy comes in with high cholesterol. He's kind of worried about his risk of heart attack. And he said, I want to get one of those CT scans. So we did. And this is the maximal intensity projection, the MIT, showing the circumflex coronary. It looks pretty darn clean. And we ran the CT clearly plaque analysis. And it did find some mild plaque, a little bit of soft plaque, that worrisome kind, in a couple vessels in the LAD and the RCA. But interestingly, in the left circumflex coronary artery, there was none. In fact, the machine detected 0 plaque in the left circumflex. We recommended a lipid-lowering agent, a statin, and he didn't want to take one, which is pretty common. 86 days later, he showed up in the ER at St. Luke's with a STEMI. He had an occluded left circumflex artery. They were able to help him open the artery. He had some pericarditis afterward. Started taking this lipid-lowering therapy with aspirin and Plavix. Then he came back to us and he's like, you know, I did that scan and I thought you guys said it looked pretty good. And I said, well, no, we said you got some plaque. We recommended statin and you didn't take it. But we started to look further at it and saw that, in fact, that circumflex artery that occluded had no detectable plaque even by AI. And I've been learning about this Briscoe inflammatory analysis, and I speak to the CEO and stuff online. He's moved to New York since, and we talk, and I said, can we run an analysis on a case? I had to go, sure, we have to get investigational approval. So we ran the FAI analysis on this guy, and he said, this came back very interesting. His left circumflex artery was on fire at that point. In fact, he was in the 99th percentile of inflammation in the left circumflex coronary artery. You know, extremely highly likely to have an infarct. He said, this guy is really high risk. And I said, Frank, I know, he already had a heart attack. This was the images that we ran on this, and he couldn't even see plaque. So the point is, this thing can see fire, inflammation in atheroma that is so shallow we can't even see the plaque. So if calcium storing is kind of old news, healed plaque. Soft plaque on a CT scan is fresher, but still somewhat old news compared to if you just have inflammation that we can see and we can't even see the plaque yet. That's the ticket. And this stuff changes over 6 months. If you give people interventional therapies, check them 6 months later, these scores fluctuate dramatically according to how you're doing with cooling the fire. Super cool. This is what I'm really excited about. So the government shutdown, you may be aware, has slowed approval of this. The FDA is sitting on this technology. They're trying to determine if it is safe to apply to your CT scan as an American. They use it in Europe all the time. We're trying to see if it's safe to use in the US. Should be likely available in July or August. We do have research approval to be using it on certain people if you want to send them over to run their CT. And you don't need the CT scan again. You can run your old data through the analysis through the cloud.
Yeah.
A couple other practice changing pieces of info you should be aware of from the last 12 months are that you can get your patients off beta blockers, even if they've had a heart attack. If your ejection fraction is over 50%, we can't find any useful benefit to being on beta blockers. It's great for systolic dysfunction. We've known that for a long time, but if your EF is normal, there's no benefit to being on beta blockers. It causes depression, impotence, impairs their chronotropic response, it impairs their VO2 max. Your patients will love you for taking them off their beta blocker. Their EF is over 50, it is okay. We've seen this over and over again. Wean them off it. Also, please try to pay attention to using aspirin for stable coronary disease in the setting of anticoagulation. Because we have seen over and over again, and finally in a big randomized trial, that you are harming your patient continuing aspirin in the setting of anticoagulation, unless you just had a stent put in. We give them DAPT briefly, then Plavix for maybe 3 months, but long-term stable disease, please don't use aspirin in combination with anticoagulation. This is in the news a lot. It's been shown 3 times in the New England Journal. Maybe we'll start to change. I've tried to change this at St. Luke's for many years, and it was very complex to do. But you can help your patients by stopping the aspirin. Doesn't help. We also are pretty big fans of left atrial appendage occlusion because these devices seem to protect you from stroke equally well to the anticoagulants with less risk of bleeding. We use a little different device than the Watchman called Amulet that we favor because in some recent comparisons, the Amulet device has been found to be favorable. It is trickier to put in. It is more tedious. It takes more time, but once you get it in, it works better. It doesn't allow leaks or blood clots to form on the device as much as Watchman. There is a concern with the difficulty in putting it in and sometimes causing pericardial effusion, but the newer generation device coming soon has a modification to times that make it safer to put in. I also want to remind you that we are huge fans of the GLP-1s in cardiology. These are not just cosmetic agents. We have overwhelming evidence in our cardiology research literature and encouragement from our society to use GLP-1s more to prevent heart failure, heart attack, because they work. Like I said, we got that lipid LDL thing down. But what's driving deaths is metabolic syndrome, and these medicines can help it. They reduce the visceral fat next to the heart that is dropping toxic cytokines on the heart and making it not work. And if you minimize that visceral fat, you can help organ function, stabilize plaque, help the patients. And it doesn't even really seem to relate to weight loss. Irrespective of whether weight has gone down, these agents are improving the metabolic efficiency, like we were showing you on the PET scan of your heart, so it works better and you don't develop heart failure and wind up in the hospital and die. We did some studies at St. Luke's using tirzepatide just for HFpEF. It worked great in the summer trial because we know the mechanism. It stops this adipose tissue from dropping all these toxic cytokines on the heart, and it improves outcomes. So we're always looking for ways to get our patients on. Do you have moderate or severe sleep apnea? Can we get you on a GLP-1? Because that's going to help your heart. It's not just for diabetes or looks. I'm also a huge fan of the SGLT2s. You guys have Jardiance on formulary here. Most of the data was just using 10 milligrams a day, and I found you usually have to get 12.5 here, like half of the 25, but that's pretty close. And this, even though it's the last agent we've introduced as useful for heart failure, it is the easiest one to introduce. Because unlike beta blockers that affect your heart rate, blood pressure, ACE that could affect your creatinine and potassium, same with spironolactone, you can start an SGLT2 without even having any labs. You don't even need to know the EF on the echo. If you see clinical heart failure, you have indications to start the SGLT2, and you can order the echo and chem later. But in a matter of 12 to 14 days, it will reduce the likelihood of showing up in the ER with HFpEF. They're that effective, and they're the only drug that works in HFpEF. All the other drugs are really only beneficial in systolic dysfunction. Again, get them off the beta blockers, get them on the SGLT2. Another thing we've learned quite a bit about over the past year, and I have myself as well, is that the number of people that have this low flow, low gradient aortic stenosis is increasing by a lot of them with the VA because it happens in older folks. And I was trained by Catherine Otto at the University of Washington, guru of aortic stenosis. And she said, all those valve calculations are measurements that can be erroneous, and then you square them. They get incredibly erroneous with all these mathematical calculations. So just look at the velocity and the gradients, which is what I've done for a long time. But it turns out there are a lot of people that can't, because of HFpEF or systolic dysfunction, generate the gradients. and they still have severe aortic stenosis. And the clue for that is if the aortic valve calculation by area is less than 1.0. So you may start to see echo reports that say the valve area is less than 1, but we don't really see pressure gradients to justify doing a TAVR. And there are so many of these people out there that you need to look further with your echo lab. There are a lot of these algorithms out there and they look pretty complicated, they kind of are, but they walk you through how, if you have HFpEF and a normal ejection fraction, you can look at the stroke volume index, the ET/AP ratio, transaortic flow, and see, or sometimes get a calcium scoring test of the valve. And if you're a man with 2,000 units of calcium in your valve or a woman with 1,200, that's severe aortic stenosis, deserves a TAVR. So pay attention to the aortic valve area on your echo report, even if it says the gradients aren't severe yet, because these other calculations looking for low flow, low gradient AS are important. And we call that classical, if you have a low EF that you can bring out with a dobutamine echo. We call it paradoxical if your EF is normal and you just do these measurements in a calcium scoring test. But a lot of people with severe AS were missing. Couple quick things on some other unique conditions that I think we also miss. The most common genetic condition in cardiology is hypertrophic cardiomyopathy. We thought 1 in 500, maybe 1 in 250. Now I think it's closer to 1 in 200 people have this. And you have to do a goal-directed Valsalva maneuver in the echo lab to find it. And if you do, we have new treatments that dramatically affect symptoms. And we even have gene transfection therapies that are curing the conditions. If you look at an echocardiogram, in your lab, you'll see the systolic anterior motion of the mitral valve leaflet, STAM, we call it, that obstructs the LVOT because the heart muscle is so thick here in the septum. It leads to this dynamic obstruction or dagger-shaped obstructive gradient on echo that you need to have your staff be looking for, especially if you have exertional chest pain or dyspnea. And if you do this maneuver well, you can find patients. But you need to sometimes have them blow into a tube to hold 40 millimeters of pressure for 10 seconds to see it. If you see it, we now know what to do about it. Because we found the hypertrophic cardiomyopathy has these gene mutations that make the beta myosin heads that grab actin filaments from the neighboring myosin filament too sticky. The hypertrophic heart has like 80% of its beta myosin head bound to actin all the time, churning up ATP, burning oxygen, causing hypercontractility, hypertrophy. So when you're 60, you're choking your outflow tract off because the heart is so thick it can't function anymore. But a once-a-day pill called mavacamten can fly in to save the day, impair that stickiness, shift it to a super relaxed state, and relieve symptoms in a matter of days to weeks. Very effective medicine. There's a new one just came out this week with fewer drug-drug interactions called aficamten. Not quite as potent, but an alternative if you're seeing drug interactions we need to worry about. So look for HOCM. If you have somebody with exertional symptoms, their coronaries are okay, think about HOCM. Have your echo lab do that maneuver. We even have a lady from Blackfoot in our practice who flies to San Francisco. She is called Cinco because she is patient number 5 in this gene transfer study where if you take an adenovirus and replace her NYBC3 mutated protein with the normal one, it fills up the heart with the normal protein. I don't know how this is done, how they get the right dose and what happens to the excess protein, but they can replace the mutated protein in the myocyte with the normal one and help to cure this condition with a one-time treatment. Crazy stuff happens today. One other condition to look for around here a lot is cardiac amyloidosis. It's 90% of people that have ATTR cardiomyopathy are white men in their 70s and 80s, and there's a few of them at the VA. There are now 3 FDA approved treatments for this condition. They really only slow progression. There are new depleters that might get rid of the protein that are promising. They're not out yet. But you need to know the clinical clues. This becomes pretty fun because in a few questions, you can find out if your patient might have this. And then you do some imaging to figure out if they have ATTR. So if you're out of breath or you have AFib or AV blocking of a pacemaker, if you've had bilateral carpal tunnel, back pain, or numb or tingling feet from neuropathy, these are clues, red flags that you might have amyloidosis. Multiple orthopedic interventions and joint replacements are a red flag. If you see these things, get an echocardiogram and an EKG. And ask your lab to do strain imaging because it gives us this pattern where even if the EF is normal, we can see that there's impaired strain that spares the apex and you get this classic ice cream cone with a cherry on top pattern on the bullseye map of strain imaging. This tells you that heart muscle is thick, not because of thickened muscle, it's full of junk like amyloid protein. And we can now non-invasively clinch this diagnosis, start therapy based on a nuclear scan. We're encouraged by ASNIC now to call this a cardiac amyloid radionuclide imaging scan or CARI. Because we used to use a bone tracer called PYP, we found that a better bone tracer that's even cheaper and works better is called HDP. That's the one we use all the time now because the equivocal images have vanished. We either see yes or no with HDP very well in a 1 hour scan. If you still think your patient might have amyloid and you haven't found it on a SPECT HTP scan, you can do MRI because MRI can see with that thickened heart, it can characterize the tissue and say, this is thick heart muscle, goes along with LVH on the EKG, or this thick muscle is not muscle at all. It's just full of protein in the extracellular space. So if you order a cardiac MRI looking for extracellular volume, it'll tell you if there's an infiltrative cardiomyopathy very well. If the ECD is over 30, kind of worrisome. If it's over 40, something's definitely infiltrating. This is not hypertrophy. This is thickening from infiltration, and the MRI can see it if you can't find it elsewhere. There are 3 drugs. They all seem to work pretty darn well. They were studied in different eras, so we can't really compare one to the other. They all seem to work pretty darn well. I think we have Bendamax here, Nalatrubie. You can obliterate production of the protein with Amvuttra as well. That's a quarterly injection. They're all ridiculously expensive and they only slow progression, but we still like to try to find it in health patients. Lastly, I think one of the most important cardiac metrics for survival, you may have heard Peter Attia and others talk about this, is your VO2 max. We've known about this in cardiology forever. It's our indication for heart transplant. VO2 max under 13 or 11, you're eligible for a heart transplant. But it's useful for other people with heart disease and even people to see whether their fitness is at a level that they could or should try to improve to help them live longer. And we're trying to offer VO2 max testing on a bike or a treadmill now at High Desert because it's an important metric to track. Lastly, I think AI, like I told you with imaging, is driving a ton of crazy, rapidly fast innovation, one of which is these digital twin ideas where we take parameters of somebody's health and make a digital twin, and then we start throwing interventions on it and watching which ones affect outcomes. These kind of things are changing the way we study patients with disease and treatments that might help them. Crazy new stuff going on. So I'm going to stop there, maybe take a question and let you get back to work. Bill.
I think the 2 questions. Okay, question number 1, the DRI, what's new variables is ADL. There's tons of people on statins. So does the LDL hemoglobin by statin affect the DRI?
No, still seems useful because it's measuring the relative particle size of the VLDL, HDL. I'm sorry, VLDL, triglyceride, and LDL. And it's sort of those ratios and particle size and particle number that give you this clue about whether insulin is affecting your lipoproteins. It's just more stable, even HOMA-IR, which we like. If you get a fasting insulin and glucose ratio, you can get this thing called HOMA-IR. It's pretty good, but it's a little less stable. It might fluctuate over 48 hours based on what you ate and how long you fasted. DRI is more of a stable long-term clue that you're insulin resistant or not, even if you're on statin, to my knowledge. Good question.
Then on the slide about the hazard ratios for different risk factors, I don't know if I just missed it, but smoking wasn't on there. That's not actually my question. My question is, so smoking rates are down, but there's this whole segment of people that are like vaping or getting nicotine, something. Is there any sort of information on non-smoking?
It was on that little slide of conditions on the right that I didn't, and I cut it off, but it was on there, but not as potent as you might have thought. Yeah. That's a number one thing we try to intervene on.
Is there data about vaping compared to smoking?
Not, I mean, that was a pretty old study. This is women's health study followed for 10 years, looking at people in their 40s and 50s. It's kind of this best, I think, long-term preventative model to say, okay, when we're talking to people who don't have heart disease, who want to prevent it, what markers tell us that we need to be doing something differently? And that's what I use that study for. But certainly vaping seems idiosyncratically make some people's lungs horrible. I don't know how to predict that, but vaping's bad. Yeah.
This might be an unfair question since it sounds like it's still pending FDA approval, but for the gentleman who had the like perivascular inflammation on CT scan, if you had that information, would you do anything besides medical management?
Again, at the beginning of my talk, I was trying to say, we're getting better and better at identifying risk. How to change people's behavior is, I think, the hardest part of my practice now, because I can tell what the risk is with precision and find the drivers on your biomarkers, recommend treatments. But in cardiology, people are like, there's, for the human in medical practice, there is now and there's not now. And if you have cancer now, you take toxic chemo. If you do not have heart attack today, if you have heart attack, we're going to cut you open, do bypass surgery. They're like, do it. But if I say we could prevent you from ever needing that with a pretty non-toxic or minimally toxic preventative medicine, right? No. So yes, I would. It's not anti-inflammatories. I don't think that's confusing. A lot of people say, can't we just measure the CRP? CRP is super non-specific. It's driven by arthritis, infection, stress, all kinds of things. It was a good first thought, but seeing inflammation in the coronaries is very predictive of concern for acute coronary syndrome. And I would treat that with aggressive LDL lowering treatment of insulin resistance with GLP-1, blood pressure control, stop smoking, check your visceral fat on the DEXA and try to get your visceral fat down, exercise more, these kind of things that we know improve after, not anti-inflammatories. Even though inflammation is the marker, I don't think it's the mark, it's a marker, not a driver, and I don't think it's really necessarily treated. I think they're unrelated. Yeah.
How do you see like insurance and stuff paying for all of these tests that you are recommending for general population?
Great question.
Yeah.
PET CT is covered pretty much across the board. It's the favorite test by Medicare. At the VA, I don't really know. I think it's probably covered. The crazy paradoxical thing is that the CT imaging is ideal for screening asymptomatic patients, in my opinion. But it was first tested in high-risk people who have symptoms, and it became part of our guidelines, class 1 indication to assess people with chest pain with CT. So it is covered, and in January there are new, not temporary, but more permanent codes to cover CT, but it's for people with symptoms. If you have symptoms, I think the PET is way better because it tells us more. Do you need to go to cath lab or not? And if you've had stents and bypass, we can't read through all that on the CT. They block out the stented segments, say not valuable. So the CT or CAC, I think is the best tool for asymptomatic patients, and it is not covered. It's cash pay. It's roughly $2,000 to get the CT scan, have a radiologist look at the lung fields, have AI look at the plaque analysis. So a lot of people do want to pay cash to know that. I mean, we do mammograms every year. Colonoscopy, the leading killer is heart disease. We can see it. But it's gonna take another 5 to 10 years for the guidelines and insurers to probably adopt this practice.
About the lab work.
Lab work's covered, pretty well covered. And it's not that expensive, Cat B or DRI. $60, maybe $50. Yeah,
I saw the slide about the CETP inhibitors, and is there any clinical outcome data for those drugs yet? I mean, I remember the torcetrapib story myself there.
yeah.
Yeah, so are there any outcome data with that with the CETP inhibitors?
No, they're underway right now, and we're doing the one in metabolic syndrome diabetics. We know it lowers LDL, ApoB, LPA. We don't know if it translates to better outcomes. We think so, but we're in a phase 3 clinical. Actually, ours is really still biomarkers, but some secondary clinical outcomes do. No,
Okay,
but it's very different. Because dalcitrapib, torcetrapib were good at raising HDL. This thing obliterates 95% of CETP activity. It's much more potent, but what we see is that drives LDL and LPA down. So that's the hope. It's not in the realm of the HDL raising that torcetrapib, dalcitrapib were trying to do. That didn't work. So it's more potent, different benefits. Yeah.
You had mentioned that the calcium score, you can't follow it over time. But still a third of the patients that have MIs, you have a 0 on the calcium score. So you wouldn't follow it over time if you have a positive, it's positive, but if a negative, you say, hey, come back in 5 years and we recheck you
You're
again.
good. Yeah,
That's kind of what you do.
good point. Yeah.
And then earlier you had mentioned, I think it was with maybe the perfusion scan that, I'm blanking exactly what the scenario was. You said, hey, well, maybe this person, we get this perfusion scan, gives us a little more information, and we see that even though he doesn't have a big plaque, his perfusion, is worrisome. I'm going to go to cath. So what would the cath do? I'm like kind of wondering, like, are our cath rates like diving down like crazy now? Like, is there any utility of a stress test at this point? It's like all these seem so much better. Like, I'm kind of wondering, like, one, I guess, when do you go to cath on that? Would rather just do another CT scan? I'm just kind of wondering how the cath plays in, I guess.
Cath rates are plummeting dramatically. Thank goodness.
All right.
Most of them were non-obstructive mild disease, no intervention needed. And you've taken risks, radiation, kidney disease, sometimes stroke, puberty. So we do many fewer caths, and our interventionalists know 70–80% of their cases are going to find obstructive disease that needs stents or maybe bypass surgery. So the findings are dramatically intense. Much fewer procedures, but the findings are usually quite alarming and need some attention. So our favorite stress test now is the PET CT scan, because treadmill echo doesn't give us as much info. But if we see focal ischemia, impaired blood flow, if it's failure to augment that flow, that suggests obstructive disease. And still, the cath can tell us if it's epicardial and fixable, or if it's normal, we'd say this must be microvascular and use meds. But you also see this group of people that have high resting flow. They can still augment decently. They don't need a cath. They don't have obstructive epicardial disease, but they have a decoupling of their cardiac efficiency from blood flow, and they're idling at 6,000 RPM sitting in a chair. And those people, you need to get an echo, get a BNP, see if you can get them on an SGLT2. I saw a patient last night. I was reading PET scans, and she came in for dyspnea. PET showed no ischemia. The resting flow was high. Hadn't had an echo or BNP yet. I mean, let's get that. That's what I'm worried about, looking at your blood flow in person. Teaches us more. But yeah, cath rates are going way down, and the CT also. So when you take somebody to cath lab, there's a high likelihood in our practice that you need something. Yes.
40-year-old people that have elevated Lp(a) waves, asymptomatic, can I get a cap?
You could. I'd consider aspirin, see if they want to do a research trial, get their LDL down to 70, ideally under 55, just because of the high LPA. That unfortunately can make LPA go up by 5%.
Okay.
The PCSK9s like Repatha, Praluent, Leqvio drop it by 25%.
How,
So if you have reasons or capacity because they're statin intolerant to switch them to PCSK9, that will help their LPA by 25%, whereas statin might make it bump up 5%.
how do we get them into the trial?
You can call our office and we screen them. That new trial has asymptomatic and known CAD arms. We can try to screen them. You only have to be 18 years old.
Here to that.
It's worth checking once. You only need to check it once. Don't even have to be fasting. But when I'm scrolling through labs, it's like, what, is your LPA high or not? We need to know. If not, check it. And you don't need to keep following it unless you get on these drugs. But for now, you just see if it's high or not. All right, back to work. Thanks for your time.
Thank you. Everyone, this is on trail. They have. It's a GRI for.
Or another version called VRI. With lab court and VRI. A lot of them just have felt in the front. Yeah.
Thank you. Oh, I got it. You just answer questions.
First thought that was actually exciting. I have a personal story which kind of surprised me. My grandfather lived to be 98, my mom 96, my dad 92. Wow. I mean,
Longevity.
yeah, I'm, my blood pressure, my diabetes, I walk 3 to 4 miles most days. I thought I had a pass. One day, I started having chills. Going up that little connecting road between, just below you, actually. Anyways, going uphill. Damn, I left my rollers at there. Next day, it was exactly the same spot.
Wow.
The following day, I went to the other end of Fairmont. It was fairly steep, and I charged up the hill and I got about a third of the way there. Oh, yeah, it was, I just, quite honestly, like I said, I thought I'd had it. Anyway, so I called Steve Ray. Stress echo that afternoon. This was in August of,
I'm sure you'll be happy.
2020. And failed that, went in and my proximal LD was like more than 95%. Yeah, I really touched.